Hello dear friends, how are you doing today? I hope you are doing well. Welcome to a new question about dermatology. A 45-year-old man has been referred to the dermatology clinic due to a new rash. He is a keen gardener and has spent the majority of the summer tending to his outdoor plants. His background is notable for hepatitis C, COPD, and hypertension. He notes this rash is worse on his hands, face, and shoulders. On examination, you note blisters and erosions on his hands, forehead, and upper back. Which of the following tests would be most helpful in ascertaining a diagnosis? A. Direct immunofluorescent staining. B. Varicella antibodies. C. Urine uroporphyrinogen. D. Serum porphobilinogen. E. Anti-tissue transglutaminase antibodies. Okay, here we have a 45-year-old man coming with a new rash. He is a keen gardener and has spent the majority of the summer tending to his outdoor plants. It means that the patient has chronic sun exposure. The history of the patient is notable for hepatitis C, COPD, and hypertension. Okay, on examination, we can see a rash on hands, face, and shoulders. Okay, the diagnosis here can be in chronic sun-exposed areas in a patient with hepatitis C. The diagnosis here is Porphyria Cutanea Tarda, and their diagnostic test for Porphyria Cutanea Tarda is urine uroporphyrinogen. Okay, here we are going to explain it. The answer is urine uroporphyrinogen. Hepatitis C may lead to Porphyria Cutanea Tarda. This blistering condition is Porphyria Cutanea Tarda. It is associated with chronic hepatitis C and results in blisters and erosions in sun-exposed areas. High levels of urine uroporphyrinogen are diagnostic of Porphyria Cutanea Tarda. Serum and urine porphobilinogen is useful for the diagnosis of acute intermittent porphyria, an autosomal dominant condition that is characterized by neurological symptoms and abdominal pain. Okay, Porphyria Cutanea Tarda. Porphyria Cutanea Tarda is the most common hepatic porphyria. It is due to an inherited defect in uroporphyrinogen decarboxylase U or OD in the liver, or caused by hepatocyte damage, example by alcohol, hepatitis C, estrogen, etc. As we can see, our patient has hepatitis C. His Porphyria Cutanea Tarda is due to hepatitis C. Okay. This leads to the accumulation of porphyrins, which are photosensitive, causing skin fragility, blistering, and hyperpigmentation, especially on sun-exposed areas. As we can see in this patient, we can see blistering, fragility, erosions, and hyperpigmentation in patient with Porphyria Cutanea Tarda. Okay, features of Porphyria Cutanea Tarda. Classically presents with photosensitive rash with blistering and skin fragility on the face, on dorsal aspect of hands. The most common feature, hypertrichosis can be seen on the face, and hyperpigmentation also can be seen in sun-exposed areas. Investigation is usually with urine. We can see elevated uroporphyrinogen and pink fluorescence of urine under Wood's lamp. Management. The treatment focuses on reducing porphyrin levels and managing underlying triggers. Main strategy include phlebotomy or venesection. The purpose is to reduce iron stores in the liver, which lowers oxidative stress and improves U or OD activity. A low-dose hydroxychloroquine or chloroquine is useful. Mechanism is to promote porphyrin exertion via their liver. Okay, avoidance of triggers. Alcohol strongly advised to stop as it exacerbates liver dysfunction and iron overload. Estrogens, example, contraceptives or hormones replacement should be discontinued if possible. Iron supplements avoid unless iron deficiency coexists, and hepatitis C or HIV should be treated if present, and smoking strongly discouraged. And sun protection is very important. Use broad spectrum sunscreen, protective clothing, and avoid sunlight to reduce photosensitivity and blistering. Okay, this was a short explanation about Porphyria Cutanea Tarda, its causes, and the management of Porphyria Cutanea Tarda. Thank you for your attention.